Good evening. Thank you for joining us for the third installment in our Custom Stable webinar series. My name is Josh Adams, the Vice President of Valley Contacts. I'm really excited about this webinar. I think this is going to be very helpful for the new Custom Stable fitters, as well as ones with a little more seasoning. The Custom Stable is a very versatile system, and as you'll see here tonight, when used correctly, has the adaptability to fit any patient that walks in the clinic. One lens, every eye. I have the honor of introducing our presenters, a couple of great young practitioners that happen to be on the Valley Contacts education team. Our presenter tonight is Dr. Cory Collier. Dr. Collier is our Southeastern United States educational consultant. Dr. Collier practices at Bascom Palmer Eye Institute in Naples, Florida, where he was tasked with creating a contact lens clinic to serve the complex visual and health needs of the diverse medical practice. Dr. Collier received his doctorate with honors from Nova Southeastern University and went on to do a residency in cornea and contact lenses at Nova. Dr. Collier lives in Lakewood with his wonderful wife, Kara, and their two greyhounds. And our moderator tonight is Dr. Jimmy Deom. Dr. Deom is our Northeastern United States Edge Consultant. Dr. Deom practices as the medical director of the Scleral Lens Institute of Pennsylvania. He specializes in anterior segment disease, especially ocular surface disease. He also lectures nationally and internationally on scleral contact lenses, dry eye, and practice management. Dr. Deom was top of the class at Pennsylvania College of Optometry and proudly served as of the AOSA. Dr. Deom lives in Northeast Virginia with his incredible wife Jillian, and their young daughter. I really hope you enjoy this webinar. Ask a lot of questions, as these guys are experts on the lens. Without further ado, here's Dr. Collier.
Well, hello everyone, and welcome to tonight's webinar. Thank you for joining us and trying to find a little bit more information on the custom stable lens. And thanks, Josh, for that awesome introduction. Jimmy, are you here too?
I'm here.
Great. So Jimmy and I will pass the ball back and forth here this afternoon and try to make sure that we give you guys some information on this really incredible and versatile lens that we have the honor to work with. So I'm going to try to keep it simple to start with and really go through some design and fitting pearls for the custom stable lens and custom stable lens system. And so what we want to get started with tonight is, first off, knowing the zones of the lens. And so if you're new to the custom stable lens, or if you've worked with it in the past, you know that the zone system is a really easy way to work within the lens system to help make modifications to fit your patients. And so we'll go over each of the zones and the power of each of those zones as well. We're also going to talk about the lineup of lenses. So by this, I mean the portfolio of custom stable lenses that we have open to us. So both all the custom stable elite, which features a really powerful back surface toric, as well as the Aurora, which has a multifocal lens option. And then last but not least, we're going to talk about over refracting with the custom stable and really trying to wow our patients with the vision that they can get out of the lens. So the zones of the lens is where we're going to get started with. So the basic design concept of the custom stable is really kind of simplified so that you can work with every patient, but this lens you'll find offers the complexity so that you can modify the lens in order to work with even your most difficult patients. And so just like when we evaluate the lens, I think it makes the most sense to kind of start from the center and work our way to the edges of the lens. And so that's what we'll do here with the lens. So this is a diagram of the custom stable 14.8 millimeter lens. And so starting in the center, the optical zone there on the left-hand side of the diagram is the central portion of the lens. This is going to contain the base curve of the lens, the power of the lens, and really fit over the central cornea. And then as we move into the periphery of the lens, we're going to look into the limbal clearance zone next, which is that transition zone, which helps bridge between the central cornea, expand the limbus, and then land smoothly onto the sclera. This is a really powerful portion of the lens. The lens design concept was really engineered with a reverse curve in this area, which just about guarantees limbal clearance in this zone. And because of that, this area can be modified and kind of either tucked in to better align with the lens or lifted up in order to give us more clearance in this area. And then moving even more peripheral is the scleral landing zone, or the final portion of the lens. This is the part of the lens which is going to ideally align with the sclera and provide us with stability, improve comfort in our patients, and really control how the lens fits and performs on the eye. And so going into the lineup, I think we'll see as we go through here, the versatility of the custom stable really shine through. And so in its most simplified version, we have the custom stable prime. And so this is a symmetrical scleral landing zone. So that means 360 degrees around the lens, the portion of the lens that's actually contacting the eye, that third zone we were just talking about, the scleral landing zone, is symmetrical, one curve all the way around. When we jump into the next, kind of the second generation version of the custom stable, which is the custom stable elite, this is going to feature a standard toric scleral landing zone. So by that we'll have a flat meridian of the scleral landing zone and a steep meridian of the scleral landing zone, which will allow us to better align with the toric sclera, especially as we move up into larger diameters. And what we'll see as we go through is that this elite can allow for so many things, such as improved centration, improved comfort, advanced customization so that we can control different portions of the lens when we want to better align the lens to the eye. And so really a powerful lens design. And then we have the custom stable Aurora, which is our multifocal lens option. And we'll really discuss that in more detail as we go towards the end of the lecture here tonight. Our diameters to choose from are pretty versatile as well. We're ranging from a 14.8 and then in 1 millimeter increments up to 17.8. And by far the most common is the 15.8. And then I think Dr. Deom and I have our patients who we like to deviate from there. And then what we'll see is as we get larger, really the biggest thing that we're doing is increasing that landing zone, as you can see in the diagram there below the diameters. And that allows us to more evenly distribute the weight of the lens and create higher sagittal depths in the lens. Dr. Jimmy, do you have a preference, maybe an example when you go smaller with the lens, maybe to the 14.8 or larger?
Yeah, I do use the 14.8 quite a bit. The 14.8 has become a favorite of mine. I tend to use it on my normal eye patients. So if I have a patient come in that has, say, high corneal astigmatism but no irregularity, then I'm going to probably reach for that 14.8 just to start with. So it's really nice to have a 14.8 set on hand. I know that you can get an abridged 14.8 set, say 5 or 6 lenses, in the office in the bell curve. Toss that on. The patient often will have less awareness and just enjoys, the comfort and optics and stability of a scleral, but not quite as large as some of our more some of the diameters that we more associate with sclerals. Something else that you'll use a 14.8 for would be a child, somebody, a younger adult, somebody with a smaller eye or a smaller palpebral fissure, just easier to get on the eye. So individuals who may be a little bit averse to a large lens and regular eyes are when I reach for the 14.8.
Yeah, I think that's a great point. And it's funny you started that with you use it on regular eyes, and being a Bascom Palmer, unfortunately, I don't see too many regular eyes, and so I find myself reaching for the 16.8 more often than the 14.8. In that I'm oftentimes fitting ocular surface disease patients. I'll go to the larger lens, and so we can cover more of that ocular surface, and continue to protect the eye. And as we continue to learn more about ocular surface and see how much not only the cornea but the conjunctiva plays a role in that too, going larger sometimes helps improve the comfort of those patients. And so I think
that's a great point, Cory. Do you fit the 17.8 at all? Is that anything you'll reach for?
I do. I fit the 17.8 in some of my patients who have incredibly steep corneas where I need a huge amount of sagittal depth, and I want a landing zone that can help me distribute that weight more evenly and not create too much pressure, but also on some of the advanced ocular surface disease patients, just to just to spread out the protection as much as possible, especially those patients with exposure who just their eyes can't protect themselves anymore. I just help protect them with the larger lens surface.
And I was hoping you would say that because
Yeah.
that's kind of where I've used it too. I actually just tossed one on somebody today. I actually fit them in a 15/8. They were a real severe dry eye patient, uncontrolled diabetes, total, neurosensory loss of the cornea. Has no idea how bad their cornea is. Tried the 15/8 just for protection purpose. It worked, but there was still this dense annular ring of dryness around the lens and a lot of discomfort. So I was just, kind of scratching my head and thinking, what else could we do here? So I did. I went for the 17/8, thought, well, let's cover more eye here, tossed it on today, and it worked fantastically. So, I think we get used to the 15/8 because it works so well for so many things. And we often forget that the other diameters have some really wonderful applications.
Yeah, absolutely. And so going into the trial lens process and understanding the lens design in more detail, the fitting sets are really set up for you to understand the lens design and understand how the lens is fitting on the eye. And so all of these markings that are on the fitting sets really just provide you with so much information. And so let's start at the bottom here, actually, at the custom stable elite lens. And so we see the three zones that we had started with there kind of demarcated on that trial lens. We have the center zone, and that's demarcated by a hash mark. And then as we move more peripheral, we've got the limbal clearance zone, and then another hash mark. And then we have the scleral landing zone, which would extend from that final hash mark out to the edge of the lens, of course. And so that helps you understand the areas of the lens that you're working with when you're trying to make modifications. The diagnostic lenses will also have the base curve of the lens. So you can see that 7.5 in the lower left corner. And then also the power of the diagnostic, which is -4. Very helpful when you have multiple hands touching lenses. And so you can make sure that your trial lens that you think is on the eye without pulling out the radioscope, which is oftentimes really helpful. And then a couple of markings that are really crucial on the custom stable elite lens are those two circles. So if we remember back, the custom stable elite is has that toric scleral landing zone. And so those two circles are going to indicate the flat meridian of that lens. And so then obviously the other two, the superior and inferior here in this picture, are going to indicate the steep meridian of the lens. And so those markings are really important to localize on the eye so that you know if you're making a change in the lens to which meridian you're going to make that change. So you always want to note where those flat meridian marks are, and we'll really hammer that home as we go through some of these examples. And the top graphic is the custom stable Aurora, which is that multifocal lens. And so it's got a couple markings as well. It's going to markate, and these are more for kind of optics marks, where we're going to mark the center zone, which will either be D or an N, depending on whether it's the dominant or non-dominant eye. And then we'll move out into an intermediate transition zone, and then we'll actually get to the edges of the lens. And so on the bottom there, you can see that D letter, which is that notating that this lens is a D lens or a dominant, so a center distance lens. And then the N lens is usually used on the non-dominant eye and is a center near. We'll talk about that lens design in a little more detail later. Another thing to note is that the Aurora will have the flat meridian marks too, because the Aurora lens is built on the platform of the Elite. So the back surface of the Aurora lens is just like the custom stable Elite with the toric scleral landing zone. This helps us improve centration and really lock in those optics on the eye. And give you the customization and flexibility to, again, independently manipulate the flat and steep meridians of that scleral landing zone to improve our lens fit. And then the last thing is, one of my pearls in working with the custom stable is over refraction and really wowing our patients with the vision that they can achieve in these scleral lenses and options that other patients in other forms of either corneal GPs or scleral lenses don't have. And so when we're working with the custom stable prime, which remember that's the spherical scleral landing zone, The overrefraction is really simple, just like we would do on another spherical lens. You would do a sphere overrefraction to the best vision. If the patient and you are happy with that vision, stop there. You can also do the sphere sill overrefraction if the vision is not where you expected or you're thinking you have some residual astigmatism. And then you would just add your overrefraction, either sphere or sphere sill, to the trial lens power and order it. So nice and simple. With the custom stable elite, we just need to think about one additional factor, which is how the lens is positioned on the eye in regards to our overrefraction. So remember, this is the toric scleral landing zone. And what we're going to do is if you have a sphere overrefraction, nice and simple, just add it to the trial lens and order that power. Of course, we're vertexing if we need to. If we have some residual astigmatism, we'll do a sphere sill overrefraction. And what we want to do at that point is really make sure we pay attention to that flat meridian marker, that circle that we were just talking about. We're going to want to document where that flat meridian is compared to 0, 180. So compared to horizontal. So let's look at this picture on the right-hand side. Or go ahead, Jimmy. Do you have a question there?
Yeah, I do have a question for you. I just want to know, how long do you wait, and how do you know that that's a reliable angle? How do you know it's at a reliable orientation?
Yes,
Number one.
that's a great question. So for me, when I'm inserting these lenses, I'm inserting them and letting them settle on the eye for a period of between 25 and 30 minutes. And so during this time period, I'm going to go see another patient in the other room, or really discuss with the patient, what our treatment protocol is and what they can expect in the future. But that'll allow the lens to really settle into the eye and give us a more reliable reading. How about you, Jimmy?
Yeah, I think that's right on as far as, what I do. And, I actually really like to manipulate it. So I like to put it on and let it sit for, like you said, a few moments, and then see where those markers go. And then I actually like to take my finger and digitally move the lens out of orientation, move it out of wherever it had landed. And then I want to see if it goes back. And, if I see that it goes back to that same location, the location that I saw initially, then I have some level of confidence that that orientation is where I could, let the lab know that I'm going to use that to put in, a toric, or just kind of have some idea that that's where we're working with. And
Yeah,
I
I think
think it's
that's
important for people to know, we talk about, and I think this is, it kind of gets lost sometimes in translation, because we're so used to talking about toric contact lenses in relationship to astigmatism. And when we talk about toric scleral zone or toric landing zone in the elite, I think we probably take for granted that most people think what we're thinking, in that has nothing to do with astigmatism. That has to do with the landing zone and the toricity of the shape of the sclera, the shape of the conjunctiva. So just to clear that up, I think everybody probably knows that, but I just want to make sure that everybody does understand that when we talk about toric landing zone, we're not talking about astigmatism. We're talking about fitting the lens in a more appropriate way, in a more suitable way, so that it is aligning appropriately with that patient's probably not spherical eye. Does that sound
absolutely.
right? Is that
I think that's a good point. And like you were saying about digitally rotating the lens, that's exactly what I do as well. So what I do is I'll over-refract the patient, and then I'll take a look and evaluate the lens. I like to over-refract the patient before I bleach their eye out with a thorough evaluation of the lens. So as long as the lens looks to be acceptable, I'll over-refract. Then I'll look at the lens in detail, see where the flat meridians are, and notate where those are, and then rotate the lens, pull myself away from the slit lamp, talk to the patient a little bit um, about what's going on, what we can expect, what's the next step from here. And then before I take the lens off again, so it's maybe only been a period of, 5 minutes tops, I'll go back in and look at it again. I don't think you have to
Yeah.
let it settle for a whole nother
Right.
20 minutes because these lenses, what we will see, and if you measure it, and if you could sit at the slit lamp for 45 seconds and have the patient blink a couple times, you'll see that rotation go
It's
right
starting
back.
to go back. Yeah.
Exactly. And so with this picture on the right-hand side, this is a custom stable elite lens, and you can see that flat meridian marker here with the circle. And if you drew a horizontal line across here, that lens is rotated to the right, so this direction, by 20 degrees. And so that's what you'd want to notate, and that's what you'd want to convey to the lab. Because with that rotation, we're going to, in kind of a roundabout way, do a LARS calculation to incorporate the prescription. And so let's go through an example where that will make a whole lot more sense
And
as
Cory,
to what
just one thing.
order. Yes.
One thing I just want to ask or add or just kind of, throw out to the crowd here, but I'm going to ask you, is when I put the lens on the eye and I'm putting an elite lens on, where do those circles go? Where should I expect them to go? I think a lot of people have that question.
It's such a good question. So the typical scleral anatomy, what we see from the toric scleral studies, is that the flat meridian is typically along the horizontal, so 3 and 9 o'clock. But that is not a steadfast rule. We'll see in all different shapes of scleras, and you will see those markings all over. And so I oftentimes have practitioners ask me, where do I want those flat meridians to be? And that's not the right question. It's just, where are those flat meridian lining up? Because it will align wherever the flat meridian of the eye is, and then you just need to document where that is. Does that answer the question, Jimmy?
Yeah, it really does. Thank you so much.
Perfect. And so as we go into evaluation at the fitting, so let's talk about those flat meridians just a little bit more here. So this is an elite lens, and this is our ideal eye. This is what we were just talking about with, typically the flat meridian of the sclera is located along the horizontal, so 0 and 180. And we'll see then that the flat meridian of the lens will align with that area of the eye. And it'll put the flat meridian marks at basically 3 and 9 o'clock, or straight across the 180. So this would be 0 rotation here. If we had basically, and if you could imagine in your eye, in your head, an against the rule sclera, so creating a flat meridian along the vertical meridian, we would have the flat meridian of the lens line up along the vertical, and we would have our circles at 12 and 6 o'clock. This lens would be exhibiting a 90-degree rotation. And so, left or right, that's at 90 degrees, it's the same. But this would be essentially against the rule sclera. Down here in figure 3, I think this will really hammer home the right and left rotation. So this is a custom stable elite with 30 degrees right rotation. So again, we'll start with our reference point of the flat meridians in a perfectly normal, eye being at 3 and 9 o'clock. That flat meridian is going to align with the flat meridian of the eye, so it will rotate. And in this case, it's rotated 30 degrees to the right from 180, or 30 degrees to the right from 0. And so that 30 degrees right is what you're going to specify in your chart, and what you're going to specify to the lab. And so if we had a sphere cylinder over refraction on this patient, what we would be doing is we'd be compensating the axis of that over refraction by 30 degrees. And since this is to the right, we'd apply a loose translation of the LARS, and we'd do left add, right subtract. And so we'd subtract 30 degrees from that, the axis of that sphere cell over refraction, and that's what we'd order. Same thing with this figure 4. It'll show you the opposite, 30 degrees to the left. And so if you can imagine this flat meridian marker here, if it started off here, it would rotate down 30 degrees to the left. And that's what you'd notate there. What's really amazing about the custom stable elite lens is that when you specify that rotation to the lab, when you get your customized lens for the patient, you're at your dispensing visit, you put the lens on the eye, and you're going to expect the lens to rotate exactly the same as what it did at your diagnostic fitting. And so if we get a repeatable rotation, then let's say we ordered this lens initially with 30 degrees right rotation, which is what this is. We put the lens on the eye. The lab has put an extra laser mark on the lens, which serves as a rotation double check. And that extra marking right here, if our rotation is consistent from our fitting, will be located right at 6 o'clock. And so you can just locate that perfectly vertical at 6 o'clock and know that the lens is performing the way it did at the diagnostic fitting. And then that can help kind of troubleshoot if we're getting some unpredictability in our vision. We can make sure that our axis is aligned where we expected it to be. So let's look at a case example here. In brief, this is a patient who was wearing a piggyback lens, and their vision in the piggyback was not acceptable. They were 20/30. They came to me from an outside provider with a piggyback. And what I could see is that they had some residual astigmatism. So I knew I wanted to build them into a lens that I could incorporate a front toric in and give them stable vision, but also correct for the astigmatism. And so this is just an example. This is our diagnostic lens up here. And so this is a custom stable Elite, which we know it's the Elite because the scleral landing zone here has two numbers, a flat meridian, this +5, and a steep meridian, which is the -2, meaning that this lens is in the flat meridian 5 steps flatter than standard and 2 steps steeper than standard along the steep meridian. So I put this diagnostic lens on the eye, and I did a spherical over-refraction, which is here, and with +1.25, they were 20/30 plus, which is about what they were in their piggyback. With a sphere sill over-refraction, which is -75 sill, I could get them to 20/20. And this is going back to that over-refract for wow. This is a patient who's been wearing corneal GPs for 30 years. And at this point is telling me this is the absolute clearest they've ever seen, only because we're dialing in that astigmatism, which on any other patient, if this was in glasses, you wouldn't ignore that amount of astigmatism. So why ignore it in the contact lens? And so let's build that into this lens. So if this is the diagnostic fitting, and this is how the lens is sitting on the eye, there's the flat meridian here, flat meridian mark here. This is rotated 30 degrees to the left. So I'm going to take that left I'm going to add 30 degrees to my over-refraction axis, which is 130, and arrive at an axis of 160. And that's what I'm going to order from the lab. Otherwise, I'm just going to add these powers to the diagnostic lens power, and that'll give me the rest of my prescription. But really, that axis is what we want to hammer home here. And so moving on into the lens fitting itself, understanding the lens design is crucial before we're getting lenses on the eye, so that way we can evaluate them properly. But let's talk about how we select our initial lens, how we evaluate that lens. Look at how the custom stable is modified through the step system, which is a really simple way to understand modification, really easy to work with as a practitioner. And then look at the scleral landing zone manipulation of the Elite and Aurora, and really we'll come back to the concept of the flat and steep meridian when we visit that point. So looking at lens selection, I always say the most important lens is the first lens that we get on the eye because it's going to tell us so much, but getting a really solid starting point is always helpful because these lenses, especially with a naive patient to the lenses, it can be a challenge to get them on in certain patients. And so we want to make sure that the lens that's on is going to give us valuable information. And so looking at the starting point here, we're going to start with the diameter selection. So in your typical HVID or horizontal visible iris diameter range, which would fall in this middle category here of 11.6 to 12.4, we're going to use that real workhorse custom stable lens, which is that 15.8 diameter. Like Jimmy was saying, in smaller eyes, pediatrics, or patients with normal corneas where you don't have a lot of sagittal depth requirement, you can drop down to the 14.8, or in those larger eyes, real large HVIDs or ocular surface disease patients will move up higher into the 16.8 or even the 17.8 lens. Once we decide our diameter, we're going to look at the fitting set, and we're going to need to select a sagittal depth or a height for that lens, right? So the sagittal depth, I like to think of as the height of the lens. It's basically the top surface of the lens down to the bottom. If you kind of set it on a flat surface, you could think of it as the height. And so the way we're going to arrive at that for the majority of us is through keratometry readings, either SIM-Ks or measured Ks. And so what we're going to do is look to the flat meridian, or the flat K reading, and we'll use a formula that only exists for Valley contacts, which is changing that flat K to microns. And so we'll just move the decimal point over 2 places. So let's look at this, 44.5 as our flat K for this patient. We're going to move the decimal point over to the right 2 places, and we're going to convert that into 4450 sagittal depth. If we're working with the 15.8, which is our general most used diameter, that's the lens that we're going to look for. There's going to be no change from that. If we go to a smaller diameter, the 14.8, we're going to subtract 400 from that sagittal depth. If we're going to a larger lens, we're going to increase that sagittal depth. We're going to add 350 to that. And we'll go to the diagnostic fitting set, and we'll find the lens that's closest to that sagittal depth without going over.
You
So
know,
let's
Cory, I think you know, you mentioned the formula or the mathematical
yeah.
equation that's kind of, you know, unique to Valley, and you're
Yeah.
right. And I think, you know, whenever I'm explaining, you know, how to use the lens to a new doc or a student, I always kind of giggle myself at that, you know, because they're thinking back to school, you know, what formula was that, or what is, you know, what are you doing there? What is that conversion you're doing? And it really isn't any real conversion, but it works unbelievably well. I mean, it's unbelievable how accurate that is, and how, you know, for sure you can be that by following that really simple, you know, get your flat K and move that decimal point over, how unbelievably close you're going to be to what your final lens is. And I think the other thing that's neat, and you're probably about to go into this with the powers, so many times the patients could see out of the lenses. It really is amazing. Um, I'd say in my own experience with following those simple steps to first lens selection, we probably get 90% of our patients in a lens that's acceptable or needs very, very little tweaks, you know, maybe one step change in the limbal zone to reduce the sag a couple microns, and we're good to go. What do you think? Do you find that
I,
that's a accurate?
yeah, I absolutely agree. If I'm changing the lens um, up or down, it's only one lens in the set.
Right.
I would say 99% of the time. I mean, this is going to give you an excellent starting point. It's going to save you chair time to take that, 30 seconds and find the sagittal depth that's right. And it just makes sense, instead of just starting in the middle, and just,
Just
blank
guessing, yeah. Yeah.
guessing. This really gives you a great starting point, gets you in the zone to be successful with this lens, and decrease the amount of lenses that have to go on the eyes, which is going to help the patient know that you know what you're doing. There's nothing worse as a patient than sitting through 10 lenses on your eye because the doctor can't find the right one. Talking
Right.
about talk about perception, to be successful with your first or second lens is crucial, I think, when you're still trying to make sure that still trying to get the patient to understand your specialty and expertise in this.
Cory,
And so
do you find that say you have a patient that comes in and they have 10 diopters of corneal cylinder, does do you find in your experience with the formula that it still works, that it still holds true, that you still
I
get pretty
do.
close?
I
Yeah.
do. I mean, and I think that that's a great point because we've got these keratoconic eyes or these post-transplant eyes that have just,
Yeah.
15, 18 diopters of cylinder I've had. And I still go to that flat K and I still
Yep.
use that as a starting point, and I'm still very successful on these incredibly complex eyes. I think that it's a
Yeah. And
great
I
start.
think it's against like your gut almost, you know. You get somebody that has a 56 steep K and a 48 flat K or something, and you kind of want to hedge your bets and go a little bit steeper or greater sag, but you really don't need to. It's unbelievable. The times that I've done it, then I see, oh man, I've got, just a whole ton of vault, and just too much. And the more we're learning about scleral lenses, we're learning that the excessive vault is actually a really bad thing. It's decreasing
Absolutely.
oxygen transmissibility. So when you have that steep, that really, big old cone, um, you really want minimal vault over that cone because you're going to have excessive vault everywhere else. So you want to kind of minimize the vault over the cone, so you're not getting excessive vault and decreased oxygen transmissibility in the remainder of the cornea.
Absolutely, I agree. So let's look at this lens selection example here, and so we'll go back to this flat K. And so in this example with a 46.5 flat K, what we're going to do is we're going to manipulate this into a sagittal depth. And so we'll look at the diagnostic lenses, and so we'll just go over, so this is 4,650 microns of sag, or if it's represented in millimeters, it would be 4.65. And so we're looking at this as sagittal depth. So we're going to go to the lens set here, and we're going to look for the lens with the sagittal depth closest to this without going over. Basically, the Price is Right rules, right? So we're going to go here. This one's 4.54. This one's 4.82. This one puts us too high, so we'll select this lens. What's really important to remember here is that we're converting the flat K to sagittal depth and looking at the sagittal depth of this lens. We are ignoring the base curve in our selection. And this is purposeful. This formula works for sagittal depth. The base curve and the power of the lenses are really compensated to help, like Jimmy was saying, to help your patient see and be able to function when the lens goes on to the eye. And then you can use, of course, the power in the base curve to manipulate the lens in the future. But we're using sag here as our initial lens selection. And so that's really what you want to pay attention to. And so once we get that lens onto the eye, we want to apply the lens. Of course, we're using preservative-free saline and sodium fluorescein within that tear bowl for our initial evaluation. And what I like to do is put the lens on and just perform a real quick preliminary fit check. And so what I mean by that is I'm looking for application bubbles. If there's a bubble, there's no way around it. You have to take off the lens and put it back in. So I'm going to look for an application bubble, and then I'm going to check for reasonable clearance. So when I'm putting the lens on, I'm looking right away when the lens just went on for somewhere about 400 microns, or the thickness of the lens, or just slightly less than that. How about you, Jimmy?
Yeah,
Initially,
yeah,
right when the lens goes on.
I'm sorry, say that again.
So right when the lens goes on, what clearance are you looking for?
Yeah. I mean, I'm looking for something equal to approximately the thickness of the lens, which, most of the lenses is around 400 microns. So that's usually what I'm
Exactly.
looking for, somewhere around 400 to 200. I think as I evolve in my scleral lens fitting experience, I'm trying to perfect it a little bit more. I think one of the things that I try to tell new docs and students to scleral lenses is don't drive yourself crazy about this. Allow the lens to settle and let the eye fit the lens and see how it feels and go from there. But I think as I'm seeing my rechecks back, from a year, 2 years now, and some even 3 years, um, I'm starting to perfect that a little bit more and go and reduce that sag a little bit more and try and aim for some smaller sags, and some decreased vaults to again maximize that oxygen transmissibility. But as a start, I'm looking for basically a 1-to-1 ratio.
I agree. And so we're going to put it on and we're going to look for that 1-to-1 ratio. And then we're going to allow the lens to settle. Okay. So we're not going to take an overly complex and extended time looking at that lens initially. Put it on, no bubbles. The tear film's about, the tear reservoir is about 1-to-1 with the diagnostic lens, which is 400 microns thick. And then we're going to let the lens settle onto the eye. And like Jimmy said, let the eye fit the lens a little bit. So after
Corey,
25,
I
30
have a quick
minutes,
question for you. You're gonna over refract, and just when you get to the over refraction point, do you find that say you're in a hurry, okay, you're in a hurry, you slap a lens on, and you're just gonna it's excessive vault. Let's say it's 800 microns, but you're just gonna tell the lab. That you want to adjust things to decrease the sag. Okay, so you go on to the refraction. Do you find that excessive vault can negatively affect the refraction, or is it something that you think is sort of a moot point?
you know, I think that it's a moot point. I always like to refract with the lens closest to what I'm going to order, just to
Yeah.
decrease the likelihood that there can be a surprise. Because do you know what wastes more chair time is a repeat visit, than doing it right the first time. But I think, and actually, as a resident, I did a research project while I was at Nova, and we compared VA equivalents and over refractions and sagittal depths of low lenses between 150 and 200, and high lenses between 500 and 600, and everything came out equal. This was with 100 lenses. So I really don't think it makes a big difference. I just like to, for my own sanity, over refract on closest thing that I'm going to order.
Yeah, I agree. I think the only time that I'll see a deviation is when you got a lot of vault and it may inferiorly displace the lens, and then you get an uneven tear film and it maybe induces some sort of different prescription. That's the only time. So I agree with you. I like to get it as close to what I want to order as possible, which for me is usually at or below 400 microns.
I absolutely agree. And so once we've let the lens settle for 25, 30 minutes, we're going to look at the lens and we're going to start in the center of the lens and move to the edges. And so we'll start with the central clearance or the central vault. So that's the space between the back surface of the lens and the front surface of the eye. And so what we're looking for here after 25 to 30 minutes, and this number keeps shrinking like Dr. Deom was talking about, but I'm looking for between 150 and 250 microns here after 30 minutes. 150 might be a little low, but somewhere in this range, because what we're looking for is enough tear film that enough tear reservoir where the lens at the end of the day won't settle into the eye. But we're looking for a minimum amount to decrease the oxygen demand on that cornea. And so I think 150 to 250 is a general consensus of a successful zone. Moving from the center to the edges of the lens, we're going to move into the limbal clearance zone. And in this area, really what I'm looking for is avoiding touch. So I'm looking for a thin layer of fluorescein out at the limbus. If you're seeing fluorescein, you're really in the range of about 30 microns. And so if you're seeing it to any extent, it's between 30 and 50 microns. And then you can go up from there. But really what we're seeing is in this limbal zone, we want to decrease the amount of clearance that's there so that it's clearance, no touch. And this will prevent, undue oxygen demand to the cornea and to the limbal tissue. It'll help you decrease debris being sucked up underneath the lens. It'll improve comfort. The lower limbal clearance over the limbus at the end of the day will feel more comfortable. You'll just have happier patients. And so kind of integrating that step system approach to our lens modification, when we look at manipulating these lenses, if we put a lens on the eye and the sagittal depth is much more or much less than what we expect, say we went through our calculation and we put a lens on the eye and it's the unlikely occurrence where the lens is too steep and we have 800 microns of clearance. What we want to do is jump right back into the fitting set, take that lens off and go down in the fitting set to a sagittal depth right away and put that new lens on the eye and go from there. But when the lens is on the eye and we've had it settle and we're looking for really fine-tuned modifications, or we're looking to just affect the limbal zone, we can use the limbal clearance zone in a stepwise approach to adjust the lens. So for Valley contacts, the plus adjustment is in the flatter direction. And so if you can think in the limbal zone, flatter will actually bring the limbal zone closer to the eye, decrease sagittal depth in the limbal zone and in the central zone of the lens. Steeper adjustment, which is the minus direction, will actually heighten that limbal zone. It'll move the limbal zone away from the eye, increase your central clearance, increase your limbal clearance. And these are, for each step, we're getting 100 micron change in the center of the cornea. So 100 micron change in the overall sagittal depth. We get less of a change, but still a significant change at the limbus. And so these steps, you can specify high or low, an incredible variety, up or down, to help you customize the lens to fit the eye. And so when we move into the next zone, so we started in the center and moving to the periphery, we're going to look at the scleral zone. And ideally here, we're looking for scleral alignment, right? Which is an even flow of blood vessels from the conjunctiva underneath the lens. And so what we're trying to avoid is the lack of perfusion in those blood vessels. So if you see a blood vessel moving in, it breaks, and then it's no longer visible within the lens, you know that the lens is compressing that blood vessel and causing a decreased blood flow in that area. We also want to avoid edge lift, which would be the opposite side of the spectrum, where the lens itself is too flat for the eye, and so it's lifted off of the eye, and there's actually a space between the edge of the lens and the eye. So when we have edge lift, we would want to steepen the lens, so move that lens edge closer to the eye. And in order to do that, we would look at the minus direction, step direction, which would steepen the scleral landing zone and bring the lens into closer proximity to the eye. When we have compression, or we have loss of that vessel perfusion, and the lens is digging into the eye, we want to flatten the edge of the lens by moving in the plus direction. Each of these steps is going to create a 30 micron change. And this 30 micron change is really affecting the edge of the lens. And so I'm not taking this into account for the overall sagittal depth for the central clearance. I'm considering each step is going to change the edge by about 30 microns, and kind of visualizing that in my mind as far as how many steps I need to make in order to align that scleral landing zone. And so a graphic that'll really help hammer home the modifications is this. If we're looking over here on the left, we're going to talk about limbal clearance zone changes first. And so standard is purple, which is the middle diagram here, this one right here. And so if we go in the plus direction, we just said the plus direction is flatter. So we're going to lift this and make this a flatter transition here. And we're going to move that lens kind of down into the eye. And so then the steeper modification, -2, that's going to move the lens down into the eye. Really hammered home in the scleral landing zone here. If we can zoom in, the purple is that standard. Again, flatter is going to lift the edge out of the eye. That's this red diagram. And then steeper is going to bring the edge of the lens down into the eye. And that's this bottom blue diagram there. And so then when we jump into the more customizable lens designs, the Elite and the Aurora, and we're looking at the scleral landing zone modifications, we're dealing now with a toric peripheral curve. So we're talking about fitting toricity. The shape of the lens is toric to better match the sclera. So the diagnostic case is marked with standard toricity, and that's this scleral landing zone +5 by -2. What does that mean? That means the flat meridian of the lens, the meridian of the lens that has the circle laser marks, is 5 flatter than standard, or +5. The steep meridian, which is the meridian 90 degrees away from the circles on the diagnostic lens, that's the steep meridian, and that's -2. So that's 2 steps steeper than standard. So you can see this toricity, we've created a 7-step difference between the flat and steep meridian so that this lens can align on the eye and better match that toric scleral landing zone. So let's look at a lens and talk about how we'd modify this. So if this was an Elite or an Aurora, which both have that toric scleral landing zone, and this was the lens on our eye, the circle's indicating the flat meridian of the lens. And so when I see patients, I draw pictures because I don't like to type a bunch of words. And so I draw these little green marks around here. And for me, what that means is edge lift. So this part of the lens is actually lifting off of the eye. And we're actually having fluorescein go inside of the lens. in this area. So this portion of the lens, which is the flat meridian, for this eye, it was actually too flat. And so we've created a space between the edge of the lens and the eye. What we want to do is tuck in this portion of the lens and this portion of the lens to better align to the eye. Since this is the flat meridian, I'm going to look at this +5. The +5, remember, is the flat meridian. And I'm going to steepen this because I want to tuck the edges in. I want to bring it into closer alignment with the eye. And so in this case, I may look at this +5 and I might bring it down to a +2, for instance. And really working with the lens and getting a feel for the lens, you'll develop an understanding of what each step means on the eye. And so I would look at the +5 and go to +2, for instance. Looking at the steep meridian of this lens, in my evaluation, I think that it looks well aligned. I don't have a mark that it's too flat. I don't have a mark that it's compressing the eye. And so I'd leave the -2 alone. And so the order that I would place the scleral landing zone would be +2 by -2. That allows me to independently manipulate the two meridians by specifying which meridian I am working with. And so I'm going to turn it over to Jimmy here. He has a little more experience with the Aurora and multifocals in his practice setting. And so I'll have you take it over from here, Dr. Deom.
Yeah, thanks, Cory. So just briefly, kudos to Valley Contacts for really, having a dedication to innovation in the multifocal space. They started out with something called the custom stable near a few years back, and through much input from their specialty fitters and through the innovation and design with Josh there at the site in Oregon, they came up with the custom stable Aurora. The custom stable Aurora is a back surface multifocal and a back surface elite toric periphery. So it is the toric lens that we've been talking about up until this point to help stabilize the lens and better fit the lens to the eye. The neat thing about this is all of the customizations available within it. So we have a distance eye and a near eye. It is a center distance in the dominant eye and a center near in the near eye. And so, this is something that, is not totally unique to the custom stable line of lenses. You may know other lenses that use this type of design or this type of eye, a distance and near design. So that in the center zone will be what is there, the distance and near in the center. Shortly after that, there is a progressive change or a reverse add on the distance lens, which you will see right in this area here. So, this is having this progressive change from the center out, especially with the distance eye, I think gives it a little bit more forgiveness for centration. Because one of the big problems we had with the custom stable near was centration. When you had a center near in two eyes, if that lens wasn't perfectly centered, you were not getting any distance or near vision quality, even with a really good pupil size. So things that you want to know here is you want to know your pupil size and the relative add power. The add power starts with a 2, and it could be completely customizable from there. So I actually was part of the study that brought Aurora to market, if you will. I had around 25 patients, all different backgrounds. We had cones, we had transplants, and I had a significant number of toric multifocal soft contact lens wearers, normal corneas with, significant amount of corneal cylinder. And I think these are the patients that are out there that we just have a really tough time fitting in contacts. They're happy with soft torics to some extent, but when we transfer over to the soft toric multifocal realm, we're just not getting consistent vision. So that was really the the group of people that I had that we had the highest success rate with. I think my previous success rate in the custom stable near was probably around 50%. My current success rate in soft contact toric multifocals is probably more like 60%. And my success rate with the Aurora has been 80 and above, without a doubt. And I'm not afraid to reach for it at this point. So this is an example of a topography of a patient that I wouldn't think twice about tossing an Aurora on. And so here you can see, just kind of taking you through without going into all the details of what lens and the sag and the power, just how the patient saw. So they came in with a distance soft contact lens, 44-year-old female. We corrected them with a refraction, got them down to 20/25. We tossed on a soft contact, and these patients, right? They're wearing contact lenses their whole life. We refract them, they just don't get to 20/20 with no pathology. They like to wear their contacts. They're not used to looking through glasses or even a 4-opter. So I'm getting her to 20/25. So my first go-to is a toric multifocal, a soft, custom-made toric multifocal. And so we get them and we toss them on. She's pretty, at first she's comfortable in them, but in a lot of these special-made soft lenses, they're a little bit thicker. They have a higher modulus, and after a short period of time, she was uncomfortable with them. And you could see that her vision was unacceptable, 20/40, 20/30, and her near vision was 20/40. She couldn't do her job that she needed to do. We then switched to a soft contact lens toric monovision. So, for me, I really want to go for multifocal optics. I'd rather them see far and close, but with both eyes, but sometimes we switch over to the mono. There, same thing, not acceptable vision distance. She had good vision overall distance, but her up close just was not acceptable. And again, uncomfortable, inconsistent vision. And I know I'm telling you a story about somebody you probably saw in your office today. Finally, we did go for the Aurora, and it was after, a couple experiences like this where I'm not going through all those steps now. I'm not going to the soft contact toric multifocal or soft contact toric monovision as a first and second line. I'm going to the Aurora first line, which is really, improved my success rate and my overall happiness from my patients. And this is one of the reasons why we have a wonderful Aurora fitting set available now. It really helps streamline the process and allow you to, pick the right lens and power and size. So here you'll see that we have, it's set up really, really nicely. Again, it's a 15/8 elite lens, and it has different near zones, so you can kind of play with the near zones, play with distance, center, distance, periphery, near center, and I've done all sorts of things with this. We recommend you start out with distance, center, dominant, near center, non-dominant, but you can tweak it around. And I've had success where I've done modified monovision. I've had success where I've done maybe 2 dominant eyes. And so it's nice to have this ability to be able to, be a little bit flexible with a fit set in your office. So, we are really happy with that option, and think that, probably you will all be as well.
Yeah.
So we have
And
some
so
advanced options here. Cory, you want to talk a little bit about quadrant specific design?
Yeah, and so we really wanted to get this lecture as an introduction to the lens and help you guys understand the lens design. And so I'm just going to tease a couple of the advanced options for us all here. So the quadrant specific option is something that's relatively new to the custom stable lens. And so this is allowing us to independently manipulate the lens in 4 separate quadrants. And that's for the limbal zone and the scleral landing zone. And I'm going to go through these slides just to kind of introduce you to this, but these are contained in our fitting guide, which is under resources on Valley Contact's website. And I think if you want to dive into these advanced options, you should really look at those in more detail. And so the quadrant specific options, again, this is allowing us to say, look at the custom stable elite on the eye. It's rotated 30 degrees to the right. And now we're not only going to be able to manipulate the flat meridian and the steep meridian, we're going to break that up into 4 and say, okay, I want to singularly manipulate this meridian because I have edge lift only here, and I want to steepen it only here. And so you can do that in the scleral landing zone and the limbal clearance zone. And as we go through, that's the quadrant specific, and kind of bridging off of that, we can also do what we call the edge vault option. And that's where we, again, are manipulating one area of the lens. And so this is great for those conjunctival obstacles like pinguecula or pterygium, and we're trying to jump over that. And so what we can do is you put the elite on the eye, see where the flat meridians line up, and then independently manipulate one quadrant. Say there's a pinguecula here, and we want to lift the lens up over top of that. And we can specify the width of what we want to clear, the height of what we want to clear, and then the edge of the lens will actually lift over top of that pinguecula, and we won't have to notch the lens to get around it. We can keep an intact lens, keep alignment across the edge of the lens as we move through there. And so an example of an edge vault here, for instance, this area here that's shaded would actually be elevated so that it can lift over top of that conjunctival obstacle. And then as we move to the right here, an even larger area of the lens that we can lift up over top. And then a new option that we're really excited about is the limbal light option. And so this option allows us to manipulate the limbus completely independently from the other areas of the lens. And so what this is designed to do is help us in our continuing advancement in scleral lens fitting, in that we want to have the least clearance that we can in the limbal area without creating touch. And so this allows us to tuck in the limbal zone closer to the eye, but maintain our central clearance as it is what we're seeing on the eye. And so we can do a step approach here. Each step will decrease the clearance specifically at the limbus by 50 microns and allow that lens to better approximate the limbus to create a more healthy zone. Our final things here are, as Jimmy pointed out, in the Aurora, we really want centration. Centration is really key. And what we've created in order to better suit our troubleshooting is the Custom Stable Aurora Troubleshooting Guide. This too is available online, and I recommend everyone who's fitting the Aurora go to this fitting guide and troubleshooting information, because until you've had a patient with the lens on the eye, I think that this will make a lot more sense when you're working with those patients and trying to troubleshoot. And we just want to present these resources to you because these are available online. They're available in your fitting guide that comes with your fitting set. And this is really where you want to consult for more detailed information on troubleshooting the lens. And we hope in the future we'll continue to have some of those customizable and increased troubleshooting lectures for you all as everyone gets more comfortable fitting the custom stable lens. Jimmy, do you want to finish us off here?
Yeah, guys, I just want to say thank you so much for coming out tonight and spending your evening with Cory, myself, and the rest of the Valley Contacts team. We really do enjoy doing this, and we hope that by offering some of this information, it allows you to expand the offerings you're already providing to your patients, and hopefully allowing you to fit just another eye with this potentially vision-changing lens. You know, we have a wonderful consultant team. I regularly talk to them all, and they just have never strayed me in the wrong direction. They really are professionals. And when you think about the number of lenses you fit on a daily basis, they're fitting, that times 100. And so their experience is vast, their knowledge is wide, and they're just the nicest group of professionals you could ever talk to. So please give them the time to help you fit your patients with more specificity and accuracy. Know that we have a Facebook group, Custom Stable Kung Fu Fitters. We're constantly updating that and putting cases up. If you have an interesting case you'd like to share with people, please post it on there and allow it to help others learn more about this wonderful modality. That's all I have, Cory.
I think that's a great end to the night. I hope, I know Jimmy and I will be at AOA in DC, so hope we can see some of you there and stop by the booth, Valley Contacts, and let us know how we're doing and let us know what more information you guys want. I hope everyone has a great night and go fit some eyes.
That's right.